that is not having great kidney function. And we have this drug that's pretty toxic and a smooth muscle relaxer that when everything relaxes in our body, that includes our lungs, this drug has a very high chance of accumulating in her system, more than we would like. So her becoming toxic from her MAG is very, very possible. So we will do periodic MAG serum levels to check if we have a therapeutic dose in her body. The therapeutic range we would like to see is 4 to 7. That tells us we've got just enough MAG in there. We should be seeing good reflexes, good respiratory rate. She should be with us and functioning well. If we have too little, she still has a chance of seizure. We probably still see pretty hyper reflexes. If she has too much, what do we see? Eventually, she's already got some kidney deficiency. If she's got too much MAG, we relax everything. Decreased respiration. Decreased respiration is going to give, or decreased or no reflexes. Because we have pretty much relaxed everything that she needs to live. So our criteria is if you see less than 12 breaths per minute with these moms, you shut off the MAG. If you have a standing order, if she's on MAG, you shut it off if you get those, or if you check and there's no reflexes.
Less than 12.
Less than 12. So if you go to take her vital signs and she's less than 12 and her reflexes are low, she's toxic, she's got too much MAG in her, and we need to stop it immediately. If you need to do that, you will also do part 2 of that intervention, which is giving her an antidote, which is calcium gluconate. So anytime you start a mom on MAG sulfate for seizure prevention, you're always going to get some MAG sulfate and keep it right next to her bed. Calcium gluconate. That's the antidote to too much MAG.
It relaxes everything. The smooth muscle, cardiac muscle, and skeletal muscle.
Everything. Right. So she's just one loosey-goosey, which is fine except for breathing and her reflex. So she needs very, very close watching. And, yeah.
Yeah, I have a patient,
Depends on then maybe who we have to notify. If she's 39 weeks, we're just gonna go ahead, we're probably gonna induce her and have her go through labor, maybe end up with a section or not, who knows, but we're just gonna handle her as a regular delivery. If she's if she's 24 weeks, it's a little bit more problematic. We're gonna have to definitely involve the NICU and the neonatologist and have them standing by. So if we've got this mom in the hospital on antepartum, we brought her in at 7 months, everybody is constantly aware that she could go at any minute to the delivery room. So you have to have acknowledged people that will all be needed for her delivery on alert at all times. So preparing for delivery really includes notifying everybody. Another thing is her family, the need for teaching and support. Remember, we talked about these people. They're not in pain. They don't look different a lot of times. We are looking at our lab results and we're telling this person, or we're looking at our vital sign results, you're really sick. What do you mean I'm really sick? And then sometimes the dad comes in, or the significant other, what do you mean she's really sick? We can't afford for her not to work for 2 months. What do you mean she's been going to school all this time and now you're not going to let her finish? What do you mean? They don't understand the severity of this. So a lot of education and support for these people is very important because, again, if they're educated, you more likely will have a compliant patient. If you're leaving out to them all the details on why this is important, the compliance factor probably will drop. So teaching and support and keeping them up to date on every little change that's going on, good or bad, is very important. Let's try another question. Oh, before I start that, think about the baby when it's born. We've on this MAG. We've had this mom on MAG for X amount of time. It's relaxed all her smooth muscles relaxed. He's going to be flaccid. He's not going to want to breathe. He's not going to want to suck. So we'll probably have pretty sad APGARs and need to be supported in terms of those first few days, very possibly. Okay, let's try our question. What information would be the most essential to pass on to the next shift in a client with PIH? Oh, PIH old-fashioned word for gestational hypertension. I use it, and they mention in your book that it's an old word, because that's what they still use in the hospital.
So you where?
It's pregnancy-induced hypertension. I don't know why we had to get rid of the word. It's the same thing as gestational hypertension, but somebody probably did a wonderful research study. So that's the old-fashioned one, but that's the one you will see in clinical or if you go into maternal child. You've not gotten on the gestational bandwagon yet. So what information would be the most essential to pass on to the next shift in a client with PIH? A, blood pressure of 150 over 90. B, an hourly urine output, which was 40 cc's 2 hours ago, 30 cc's the last hour. C, a respiratory rate of 20 per minute. D, right upper quadrant pain.
D.
Everybody agree with D? Syndrome, we kind of diagnosed and found out about or labeled it as such a syndrome only in 1982. It has not been diagnosed or identified as a disease process for very long. And what it is, it's pretty much preeclampsia on steroids or supercharged. It's preeclampsia as worst as you can be. And it's a combination of lab values. So you're gonna see, looking at your patient, the exact same looking patient you had when she's preeclamptic, is you're gonna get her set of lab values and you're gonna go, she's got HELLP syndrome. And HELLP syndrome is an abbreviation for hemolysis, which is where we get our H, elevated liver enzymes, where we get our EL, and low platelets, we get our LP. All those things we talked about on that chart that we could see in preeclampsia, now we're gonna definitely see them. So if we've got those three conditions in our mom, she has HELLP syndrome and she is critically ill. She's at risk for everything that we talked about, but more at risk and a more severe version of it. So that includes the hemorrhaging, the pulmonary edema, the hepatic rupture, the renal failure via abruption. Again, her RBCs break down as a result of the vasospasms and the constriction that causes damage to the red blood cells. Her platelets are clumping all along those damaged areas in the vessels. And then the liver enzymes increase when their blood flow is decreased to the liver because of all the deposits. And the prominent symptom of HELLP syndrome, again, is the right upper quadrant pain or the epigastric pain. And these women have a very high chance of not surviving this. This is a very, very serious disease process. I think your book says the mortality is about 24%. And think about it, in our day and age, with all our technology and our knowledge, there's still 24% of these women that we can't save.
Yeah. How often do you see this?
Luckily, not too often.
Have you seen it?
Yes. And I've seen them all die. And there can be degrees of HELLP syndrome. So if she's just got a little hemolysis and her platelets are just a little low versus totally bottoming out. I mean, the people I have seen that had it severely, you're pouring platelets into them and it's just not making a difference. You're pouring blood into them and it's just not making a difference. I think, again, I'm looking here at my notes, I think your book says about 20% of people with severe preeclampsia develop HELLP syndrome. And again, your book's kind of old, so I don't know what the statistics would be now. We're getting better diagnostics, we're getting better treatments, but it's still very, very serious. Because there's nothing you can do, you just watch the woman go. Because you're putting the blood products into her, which is her need, but they're just not having any effect.
Does it increase the platelet aggregation?
I think that's part of the problem. You pour the platelets in, but you're not seeing them when you draw their samples, so it's not around to help her with her circulating platelets. Yeah. That's all I got. Questions? Can't come.
No problem. Okay, I need to set up my iPad because it's not going to work. Are these good?
Did she mention it? She wasn't copy of your
No, it's more like just lazy.
I was nervous at first when she asked me. I thought she was confused. I was like, I didn't know. When she wants a copy, I know her, I know her.
Get started, please. Yeah, so, I can wait or do you want to now? Okay. Betty. Betty. That's Betty. Dad. Jennifer Colchick. She's right. She's not there. She's right. She's here. Okay. Which one? Michelle. Linda Cerniglia. Linda, there you go. Okay, Nicole. Yeah. April. Bitsy. She is, there she is, I'm sorry. Okay. Blaine. Laura Hadley is Dawn Harris. Hey. Okay. Mary Louise is here. Melissa Lawler. Catherine Ludwig. Dominique Fashio is here. Jim Wire. Right here. Abe. No, Abe has moved. Sarah McGreevy. Oh, I know, but I'm like, two questions. Hey, in the finals, you test the same, I mean, do they give you the same type of questions? They test you on a new part of the question. Like the we have like the same portion, or it'll be slightly other different.
I'm more about the final. I'm more about the final. Like cumulative final, like really makes me nervous all the time.
Okay.
I'm not saying anything of my fault.
Where are you?
I can just call every Friday morning. How do you do? Okay, I don't know what I do. From my parents.
Okay, so just to remind you guys that we are available to review after class, so please. This is kind of when things start to get
Next one has more
a little more stressful, not that it's remotely possible for them to possibly be more stressful perhaps, but sometimes that does happen, so. Please come visit us if you have concerns about this particular grade or any grades that are happening at this point in time, okay? Because if you have concerns, we probably have concerns as well. And we'd like to see you, but that is, it's your responsibility to come visit us and do your business. So please do so. It's really another need, and
And I would certainly say that if you've got below passing on this quiz, that you need to be going to see someone. I mean, you're starting to, you know, this is quiz 3, you've got 2 more, so it's time if you haven't particularly, you haven't reviewed with one of us to do so. Okay, so I'm gonna talk about bleeding in pregnancy, and I'm also gonna talk about sexually transmitted infections today. Bleeding is the first topic we talk about this particular week, because we're talking about acute problems in labor and delivery, and if there